Hi, it's Steph here. In this episode, I'm going to have a Q&A session with a AI chatbot. I recently discovered the OpenAI chatbot, which is still essentially free to use. To be more precise, it gives you an $18 credit that lasts forever with an expiry date of 3 months. I've asked it a lot of questions, used it for many uses, and it barely touched my credit score. I'll put the link of this chatbot to my profile below, but I'm going to have a fun episode today. Let's see how smart the AI chatbot is in terms of answering healthcare questions so that we can kind of gauge whether this will eventually replace our jobs in the future. Question number 1. Is it true that if you're allergic to penicillins, you cannot take any beta-lactam antibiotics? This is actually not necessarily true. Up to 20% of patients admitted to hospital report that they have a penicillin allergy. However, only less than 2% are found to be truly allergic. To more accurately assess a patient's allergy history and to see if they may be able to tolerate another beta-lactam involves knowing the type of reaction that they developed to the initial penicillin in the first place. Drug hypersensitivity reaction usually falls within 4 broad categories. Is it an immediate IgE-mediated reaction? This usually occurs within 6 hours of taking the penicillin and usually manifests as urticaria or hives or anaphylaxis. Or is it a delayed reaction without systemic involvement? Or it can be a delayed reaction with systemic involvement, such as a severe cutaneous adverse reaction, including Stevens-Johnson syndrome or toxic epidermal necrolysis. This usually occurs within 1 to 6 weeks of exposure to the drug for the first time. And the last category of hypersensitivity reaction is just other reactions that don't fall into the 3 above categories, such as serum sickness-like reactions, cytopenias, drug fevers, or nephritis. And their onset usually ranges from within 3 days of taking the offending medication to up to 4 weeks. This is just a very brief summary on how to assess a patient's beta-lactam allergy. I would encourage you to read up more on this topic, as there is definitely more to it than what I have just spoken about. In a patient with a history of an immediate IgE-mediated reactions, such as those with previous hives, urticaria, anaphylaxis, for example, and with a history of a penicillin allergy, they may still receive non-cross-reactive cephalosporins, such as cefazolin, ceftriaxone, and ceftazidime. This is because newer evidence have shown that cross-reactivity between a penicillin and cephalosporin is due to the similarity of their side chains, as there would only be a significant risk of cross-reactivity between those with a similar side chain at either C3 or C7. In patients who report a delayed hypersensitivity reaction to beta-lactams, there's currently a lack of data informing the cross-reactivity between beta-lactams. Therefore, management strategies tend to be more conservative in those with a delayed hypersensitivity reaction. In patients who report a delayed mild rash with no systemic involvement, such as without fever, no involvement of the internal organs or mucous membrane, a beta-lactam antibiotic from a different class may be considered. For example, if the patient reports a delayed hypersensitivity reaction without systemic involvement involves a penicillin, then one may consider using a cephalosporin. However, in patients who report a delayed reaction with systemic involvement, which includes severe cutaneous adverse reaction, including Stevens-Johnson syndrome, toxic epidermal necrolysis, previous stress, or serum sickness-like reactions, cytopenias, nephritis, for example, we should avoid all beta-lactam antibiotics because of the severity of the nature of the reaction. My second question to you, OpenAI, is nitrofurantoin contraindicated in those with renal impairment or a low creatinine clearance? This is actually not necessarily true, as according to the Beers criteria of 2019, short-term therapy with nitrofurantoin could be used down to a creatinine clearance of 30 mL per minute. The third question for OpenAI is taking antibiotics for a longer duration better than a shorter course? Wow, that is correct. I'm surprised to see that they built in some clinical knowledge into these AI applications. Newer evidence that are coming out are generally supporting shorter courses of antibiotic therapy for commonly treated infections. I'd like to refer you to an amazing clinician that I follow on Twitter named Dr. Brad Spellberg. On his Twitter account, he has this fantastic table on the summary and the number of studies that are supporting shorter duration of antibiotic therapy for numerous infections. And lastly, I'll let OpenAI end this episode with this question. Does a positive bacterial culture always mean that there is an infection? That is correct. A positive bacterial culture does not always mean an infection. It could represent colonization, and further testing and investigation is required to tease out whether this represents a true infection or not. Can AI replace healthcare workers? It's great to hear that currently artificial intelligence does not have the capability of replacing the clinical judgment and assessment of a healthcare worker. Therefore, establishing our thought process, especially when evidence is limited, is what I think healthcare workers such as pharmacists and clinicians bring to the patient care team, especially in the digital era where artificial intelligence and machines are threatening to replace human workers.